Hello everyone. I'm Julia Climaco. I'm a researcher at the Northern Center for Clinical Research, which is a partnership between UNBC, University of Northern British Columbia, UBC, and Northern Health. And I'll be sharing with you today um, an environmental scan we've been working on for the last couple of months. It's called Navigating Healthcare Access in Northern British Columbia, and it's an environmental scan for remote, rural, and Indigenous communities. Prince George UNBC campus is located on the unceded territory of the Claytene, which is part of the Dakel First Nations. And this is a work that I did with my colleagues at NCCR, and Dr. Anurag Singh is the PI. So first, I'm gonna talk a little bit about what's specific about Northern British Columbia, because we are in this conference talking about remoteness in northern regions. But I think what's peculiar about this region is that it's super big. It's almost the size as France. It has around 650,000 kilometers and a very low density population with around 289,000. And another specificity is that 17% of this population are Indigenous people. And another thing is that it has the lowest health status in British Columbia. And the region is pretty diverse culturally, but its economic is mostly resource-based. That's another thing that we will be addressing when we talk about the barriers in the access. But regarding cultural diversity, we have over 54 Indigenous communities and with 17 linguistic groups. Well, what rural, remote, and Indigenous communities share in this area is the experience of harsh climates with very hard winters and heavy snowfall, and summers increasingly warm, and the wildfire has been a very serious issue around here. They also have small populations, small and spread. They also share the lower incomes and educational levels. And again, there's a higher proportion of Indigenous residents in the area. So about healthcare access in Northern BC, a couple of ideas motivated this environmental scan. So there was some problems that had been identified in the literature. So we wanted to understand if we could find specific things about this region. What we started with was knowing about the long travel distances that people need to go through to access essential medical services, the financial burden of these long travel distances. And here we can talk about direct and indirect costs. And then we also have extensive literature talking about how Indigenous communities face additional challenges from a lack of culturally sensitive healthcare services and, of course, of a historical myth towards Western and colonial medicine. And the region also lacks services and lacks infrastructure in the delivery of healthcare services. So making people having to go from their rural communities to their big urban centers. And in this case, it's here in Prince George. So the main objective of this environmental scan was to explore the barriers, hardships, and facilitators associated with healthcare navigation and access for people from remote, rural, and Indigenous communities in Northern British Columbia. And we had a couple of critical analytical questions that we read the literature with these questions in mind, trying to find answers to them. So I'm going to just go through the question. How does geographic isolation impacts the availability and utilization of healthcare services in northern BC? What are the specific barriers and facilitators affecting the ability of Indigenous populations to access healthcare in the region? How do economic factors such as the cost of travel and loss of income affect healthcare access? And how does the availability of healthcare professionals in northern BC affect service delivery in RRI areas? So to do this environmental scan, we followed the BIGS protocol until the selection of literature. We didn't do a scope review with it because we didn't have a double-blind evaluation. We selected papers from 2014 to this day, and the database were PubMed, Scopus, and Web of Science. We used a couple of research terms, all related to healthcare access, financial barriers, remote health, rural health disparities, Indigenous health, and northern BC. And you may imagine that we found very little about this, specifically in this region. So we expanded the inclusion criteria to include studies that could provide insights into healthcare accessibility, its challenges, and we tried to find them in northern BC, but not being able to, we expanded it to comparable regions with similar geographic and demographic features, but in Canada. The exclusion criteria was, of course, studies from outside Canada, and also studies that did not focus on a rural perspective and were not from a patient's point of view. So the barriers, we found plenty. And the first and most important one that the literature always refers to is the geographic and logistical barriers. Because of the vast distances, the challenging terrains, because of mountains especially, and because there's a lack of public transportation and paved roads in this area. So we don't have a public bus system that can bring people to the urban centers with regularity, meaning that sometimes they do need to spend more than a couple of nights to have access to any type of medical service. We have few and expensive commercial air transportation. And there's also a very serious lack of cell phone services, which make it difficult to even communicate and organize the service that they may need. This made them rely a lot on emergency services, which is not great. And again, during winter, the snow can isolate communities, and in summer, the wildfires can isolate and also lead to evacuation, which further complicates, especially for people with chronic conditions. And tied together with this, we have the financial barriers, which are the high cost of out-of-pocket travel expenses, especially with chronic conditions that make people have to do these travels repeatedly and with a certain regularity. So inside these costs, we can count for transportation, accommodation, but also what we call the indirect costs, which are the loss of wages and also the delay between exams and appointments, which make people sometimes have to do more travels or also spend more time in a certain urban setting. Specifically about Indigenous populations and newcomers and immigrants, we have cultural and linguistic barriers, which can lead to misunderstanding, mistrust, especially for Indigenous population, what they understand as a colonial medical approach, which can result in misdiagnosis and non-adherence to treatment. There's also the region, as in many other northern and remote regions in this country, there's a high personnel turnover, which means people come and go in a very high frequency, meaning that there's always a disruption in the continuity of care, and which also impacts the establishment of trust between patients and their providers, and which can also result in non-adherence. And they also have to repeatedly explain their medical histories, which can even lead to large files, and they can be labeled as complicated or difficult patients. And also new providers that come and go all the time, they're not familiar with the communities and the specificities each community face. So there's a big reliance with temporary locum staff who come, and what they call, it's not about health, it's about sickness. They call them sick clinics because they only come, see what's going on, what's wrong, and then go away. And again, there's a lack of basic medical infrastructure in many of these communities. They don't even have clinics or diagnostic equipment, and not even to mention specialized services. And when they do have some of these, they can be outdated and under-resourced. Makes it very difficult also for the providers to be able to provide good care. And this means also that they do not get the care that they need in a timely manner. Facilitators, we have the telehealth and mobile health services, but again, remember that one of the things that is specific about this area is the lack of self-service. So this can be a facilitator if we have the proper conditions. Also, the long-term and sustainable partnership with healthcare providers, academic institutions, governments, and local governments has been pretty effective. So has training local people to become healthcare providers, as is the Northern Medical Program with UNBC and UBC. Community-driven health initiatives and peer support programs have helped people, especially in their adherence to medical treatment. And of course, culturally sensitive healthcare services. And having financial support mechanisms to provide people with the condition to go through these pathways. And not only have the services, but they also need to be easily accessed, because there's also the complaint about how difficult it is to access this, especially in emergency situations. So just having them and not having them accessible to the population in these areas isn't good enough. So we concluded that the diversity and complexity of these journeys in this geographically dispersed region is significantly under-researched. And we do need more detailed studies about medical journeys, because we go around these same problems that many of the literature focuses on, but they don't bring many specificity of the region, which makes it difficult to address in a public policy way. We also need more studies about chronic conditions that require repeated travel. And we also need to understand what socioeconomic factors on this access impact more and how we can address it. And we also need to investigate the role of community-based and culturally sensitive interventions to improve local outcomes. So regarding the gaps in the literature, we found that we do need more specificity and the quantification of hardship. Because one thing is to say that there's a great economic burden and financial burden on these families, but we need to, if you don't have a number tied to that, it's very difficult to actually build public policies around it. So we need studies that focus on actual financial hardships. And there's also a lack of intersectional analysis. So we do not know a lot about the experiences of immigrants, newcomer, or racialized groups in general. And especially we do not see a lot of gender analysis. So we don't understand the extra financial hardship that women go through, because they're usually the main responsible for care. So they go through hardships not only when they seek health treatment for themselves, but when they are responsible for accompanying or children or elders or even partners. So we do need more intersectional studies. And also, it would be really interesting to have more research to understand barriers that patients with chronic conditions face, again, because of the repetition of the travel that they need to go through. So the next step of this research, we will be focusing on trying to quantify this hardship, especially with people with chronic conditions. And we want to see this hardship on the whole medical journey, from seeking a diagnosis and then accessing the actual care, especially specialized care, how this will look. And that's it. Thank you. Thank you for listening. If you have anything that you would like to add, if you have research that you would like to share, that's my email. Again, we didn't find much about it, especially in northern regions in Canada. So please share your thoughts.